everybody, and welcome. I'm Gayle Schmidt, the president and CEO of the One Campaign, former administrator of the U.S. Agency for International Development. And we have no small task here. The name of this panel is Implications, What the U.S. and the World Should Do. So in 42 minutes, we're going to lay out a map for the future and everything that needs to be done. I'd encourage you to go to your program information for the in detail bios, but let me just briefly introduce Amanda McClelland, who's the SVP at Resolve to Save Lives, Dame Sally Davies, who's the UK Special Envoy on AMR, but has been the Chief Medical Officer to the UK government, Dr. Mukherjee, who's an esteemed professor at Brigham and Women's Health and also at Harvard. And what I'd like to do is set the stage a little bit and then ask each of you to respond, if I may. I think when reviewing the study, the comparative study that was done, the thing that strikes out the most to me is that facts have now become opinion. And we are dealing with a crisis that is in many ways quantitative, unlike something like 9/11, where there was a lot more human variation, political variation. And when facts become opinion, all of the ingredients we need, data, science, engineering, a systems approach, become quite muddled. I think the second is that I think it's fair to say we have seen one of the greatest failures in global leadership, certainly that I've seen in my lifetime, in managing a global crisis. Right now, we have a very fragmented response, and one that, like it has in each of our countries and communities, exposed tremendous inequities. The last point I would make, since we're focused on preparedness, is as we go into this discussion, let's think about not just the pandemic we're in, but as we all know, the global health security threats we will face over time. Because one of the greatest mistakes that is often made in the wake of an emergency is to plan for the recurrence of that same emergency. And I think we all know that the pattern of the future is one where we're going to see more of this. And so our ideas for what the world must do and what the US must do need to be rooted in that. I'm going to stand in a little bit on the US. Samantha Power is not joining us this morning. The announcement of her nomination to serve in the Biden administration came out this morning. She sends her apologies. We send our congratulations. So let me start and ask if each of you would briefly share your thoughts on your perspective. How do you come into this issue, right? And what's the lens through which you're looking? And as we think about what the world must do, what would you say are the two most critical things? If you were in charge of the world, what must the world do? And let me start, no pressure, with Amanda.
Oh, thanks so much. So my lens on this, I think, as a registered nurse who spent a lot of years on the front lines, I think my lens on this was understanding after many years of responding to natural disasters and epidemics around the world that I was going back to the same countries for different problems over and over again. And not long after West Africa Ebola moved into preparedness, so now lead a team at Resolve to Save Lives, focused on preparing countries and their health systems for epidemics. And I think it was no surprise to anyone that the world wasn't prepared for a pandemic. Everyone, the people that have been working on this have been saying it for a long time. But there were countries that had made progress. I think there was significant work being done in a number of countries, and we have seen those countries be better prepared than we thought they would be for this type of event. But we've also had a lot of people ask us what went wrong, and the tools that the WHO and others were using to measure preparedness, to facilitate preparedness, weren't enough or weren't there. And I think people are looking for the silver bullet, what went wrong, and what do we need to do to make it right. And I think there's two things from my side. We have this false dichotomy of science versus opinion, livelihoods versus lives. It's an either or, rather than really taking a systems approach, as you said, and looking at the pandemic and the systems that it's affecting overall. And so the two things I would do if I was in charge: invest more in public health, longer term sustainable investment, And I think social cohesion and trust, I think we have to get back to building our engagement with communities constantly, not just when we need them to make behavior change.
That's really, really helpful, and I think exactly on point. Let me turn to Sally for the same question.
Thank you, Gayle. So I started wondering about this question back at the beginning of March. You know, how could we be better prepared next time? So what was missing from the recipe now? And I want to start with data. We need the right data in the right place so people can take decisions, and we need a really tight feedback loop. But then that takes you into thinking what sort of data. And it's not just surveillance data that governments or government agencies may have. It's behavioral data. It's big social science issues about movement and attitudes and expenditure, things like that. And who holds that data? Well, clearly that data is not held in the public sector, it's held in the private sector. So what we looked at, and I will talk more about it if you'd be interested, is how you bring together the private sector with their data and their expertise with academia in order to help make sure that you can start to know what's going on, to be able to model it effectively and model the appropriate responses and move forward. And that effort is called the Trinity Challenge, and we have Facebook, Google, Tencent, Aviva, Discovery, Optum as private sector, and top universities from all around the world as partners working together through a challenge methodology or direct collaborations to try and make sure that we can get the data to the academics to answer the questions the public sector needs to answer.
Superb. And I think you're absolutely right. I think, unfortunately, what we've got now is a very fragmented kind of collaboration as opposed to a systemic collaboration. So we've got a lot of initiatives out there scattered around the globe. But I think part of the challenge is how do we knit those together? Because you're absolutely right on bringing all the sources of data together. Dr. Mukherjee, let me turn to you.
Yeah, great. Thank you so much, and it's a pleasure to be with this esteemed panel today. What you didn't mention, Gayle, which is the role in which I know you, is I'm the Chief Medical Officer of Partners in Health, which is a 30-year-old international medical charity that works in 11 countries around the world. And we work to help to build systems long-term with both governments and civil society. So our work in Haiti, for example, for over many years, we helped to rebuild a dozen public facilities, hospitals and clinics to train doctors and nurses, to hire and pay and supervise and train an army of community health workers. And we've done that throughout the world, having a staff of about 17,000 people that work with the public sector. So how does that link with preparedness? Well, we really think that separating pandemic preparedness from the notion of really delivering day-to-day high-quality care is a mistake. Preparedness is not separate from those things. And I think, for example, we were pulled in and invited into Liberia and Sierra Leone during the Ebola epidemic. And we said, yes, we will help stand up Ebola treatment units, but we also will look at what makes the health system, what can make the health system stronger. So we started to improve the basic district hospitals, health centers, put in an oxygen plant, all for the public sector. So fast forward to the next pandemic, we have oxygen. And I think this is the important thing about you can't fight the next war based on these particular things. You can do a lot of IPC, but you don't know when you're going to need oxygen or blood transfusion. In Haiti, for example, after the earthquake, we already, as part of health system strengthening, had stood up about a dozen operating rooms. So while we didn't have enough orthopedic surgeons, we had space with anesthesia machines, modern operating theaters to bring in people who could do the vast numbers of orthopedic surgeries needed. So the first thing I would say is, if I were in charge of the world, I would say high quality healthcare for everyone is our best protection. And then I would say, in terms of what went wrong, and the most surprising thing, at least in my own country of the United States, is we don't have that high quality care. And we should measure our success not by the spending on healthcare, not by the shiny things in the highest level hospitals, but by equity. And when you look at the United States, it is one of the most inequitable societies in terms of health outcomes. We have, in my home city of Boston, a 30-year life expectancy difference between a Black American neighborhood and a very affluent white one in Boston itself. 30 years, 6 minutes on the subway. So I think in a lot of the preparedness rubrics, we don't include these social factors like racism, like inequality, like investments at community level. So I would say the two things we need to do is say, what is our cosmopolitan, truly global notion of healthcare as a human right? And how do we measure it by equitable provision of care? And if we do those two things, we would be prepared for the next pandemic.
Let me just say, I think I've had the good fortune in my life to have touched all of yours, including Partners in Health, and your role in both Haiti and in the Ebola epidemic. And I think one of the takeaways from the Ebola epidemic was that it was possible to respond to the crisis and build capacity at the same time. And I think we disaggregate these things. And then what happens is, between crises, nobody does much of anything, which gets back to Amanda's point about the long-term and sustainable investments. I couldn't agree with you more on the equity piece. I think one of the most dominant features of this entire crisis has been the exposure of gross structural equities in a way that we ignore at our peril. And let me switch hats now briefly as a panelist and answer the question in terms of the US. And I think a lot doesn't need to be said. I think we've seen a colossal failure in the United States in terms of the response, including for the reasons you point to, which is the underlying foundation is so inequitable and so uneven that even an ineffective or a fully effective response would fall short. But when I look at these things, I think there are three ingredients that are needed. One is capabilities. And it's both existing capabilities and how do you respond and build them at the same time. The second is an engineering and systems solution, which is, in the United States, for example, we've had next to no guidance from the federal level, each state left to do what it thinks is the best. And there's no guidance on either the science or, Sally, to your point, the social dimensions. So we, by definition, have a very fragmented response. The third is political will. And I think we've had two problems on that front here. One is stepping up and investing the political capital to actually lead. But I think the other problem that's occurred here and around the world is that, unfortunately, political leaders do not want to share the truth with constituents. They want to tell constituents what they want to hear. And in a time when it's people's opinion, where wearing a mask is a question of personal freedom as opposed to a fact of science and public health, if you are unprepared to speak truth to the people you lead, you're going to get the outcomes we're seeing right now. So in terms of what the US needs to do, I think you all have actually defined many of those pieces. Equity, to me, is at the core, that unless and until we build health systems around the world that are comprehensive, that are also affordable and are equitable, we are not going to have the foundation we need to respond to future global health crises that we know are coming. I think the second, obviously, an incoming administration, this administration is going to face huge challenges, increased dramatically by the events of last week, which have been building for some time, are going to be with us for some time. So it's going to be getting the pandemic under control here, but it is certainly my hope that the incoming Biden administration will take the lead by putting facts and science out there, pulling in that social data and analysis. I think the third is building a comprehensive response, and Sally, you're absolutely right, where you pull in the public sector, the community sector, the private sector, the academic sector, but in a way that is systemic. We cannot afford a series of one-offs that look great for events. We actually need to knit these pieces together. But I think the last challenge is the US stepping up with other countries to play some role in terms of global leadership. We have a pandemic that we know is driven by a virus that moves across borders, within countries, across countries, and we have no global supply chain or even baseline knowledge. We've got uneven sharing of data and science. Many of the scientists and data specialists are sharing it, but there's no large cover for that. We have no global strategy for vaccines. And what are we seeing as a result? We're seeing a pandemic that is still unchecked, and we're seeing inequities grow greater rather than coming under control. So I want to bring into the discussion, because there's a really key question from Anjali Rohn, who's at MSF, that I think merits coming in now, and then let's factor it in and go another round. And this question has to do with the fact that if you look at what countries around the world have done, mine included, is to invest billions of dollars in scientific research and the development of therapeutics and vaccines, including for this pandemic. And ostensibly, one would assume that is done on the basis of believing that these are at some level global public goods. But on the other end, there is no system, no safeguard, no policy, or no guidance that says, yes, these things should therefore be used as global public goods in the actual application. So that we have a situation now, for example, where yes, we have vaccines, but we have nothing near the kind of equity that we need, not just for fairness and what is right and wrong, but also what the epidemiology tells us about how to actually gain control over the virus. So Anjali, that's the question to you. Maybe you can bring that piece into the discussion, and then let's do another round.
Great.
Hi.
Thank you so much. Hi. As mentioned, my name is Anjali Rohn, and I'm the Director of Communications for Doctors Without Borders in Canada. And my question for the panelists, as mentioned, we know that higher income countries, including the United States and Canada, have amassed a large amount of COVID-19 vaccines, which is excellent, but perhaps more than is required for the populations of those respective countries. So for my question for the panelists is, what is the responsibility, in your view, of governments in high-income countries to redistribute and donate these surplus vaccines to lower-income countries who are in critical and immediate need for these vaccines? Thank you.
Okay, so let's do another round. It's a great question. And again, feel free to answer this. If you were in charge, what does the world need to do? What does the US need to do? Amanda, let me turn to you first, and we'll go in the same order as we did last time.
I mean, I think WHO has been very clear on this. We're not safe till everyone's safe. And so there is we're only going to beat the virus with global solidarity. So I don't think there's a question there that high income countries need to do more to support lower income countries to not only get the vaccine out, but other tools. I mean, the shortage of PPE in many locations is putting lives at risk. We've lost thousands of healthcare workers. So as much as the public good and the investment in vaccine is critical, and there needs to be more solidarity and equal distribution of the vaccine, I would go beyond that for testing capacity, other diagnostics and treatments, all the way down to PPE. I mean, we're releasing a report today on healthcare worker impact because of epidemics. Tens of thousands of healthcare workers have been infected because we couldn't get simple masks and gloves out to the healthcare workers that needed it, not just in Africa and other low-income areas, but in the United States. We've seen, huge amounts of healthcare worker infections. So I think vaccines is a hot topic and something where we need to see global solidarity, but it's not the only public good we need to make sure that there's equitable access for.
I totally agree with that. Thank you, Amanda. Sally, let me turn to you.
So we've got to start with having the vaccines, and that means sharing genomes. And having vaccines is based on both long-term investment in novel ways of making vaccines, and vaccines for, say, MERS in the same family and things like that, and then investment. And thank you, Germany, Britain, and the States for such large investments. But once you've made them, you've got to think, are they affordable? And I'm very proud of AstraZeneca, who are cited here in Cambridge. I'm Master of Trinity College in Cambridge, who are providing their vaccine at cost for the duration of this pandemic. But once you've got that, we need the logistics. And that's quite complex. We haven't, outside smallpox and polio, really gone for mass vaccination across the world for many decades. And we're having to relearn how to do that. And I'd go back to, you actually need a data architecture and data to be able to collect it. If you look at PPE, what we found in Britain at the beginning was some places had PPE, some health centres didn't. And it wasn't until we got the logistics sorted and the data sorted, you knew where you could move it from and to. So that's at the microcosm of a nation. And what you're arguing for is how we do that at a larger level. But, even if we've got the vaccine at cost and we've got the logistics, where's the funding for the low and middle income countries? And of course, I'm proud that we've, from Britain, contributed to COVAX to buy a lot of vaccines, and we're one of the big funders of vaccines for low and middle income countries. But we can all do more. And I think I would end by going back again to the social sciences. We need to make sure they're affordable, they're available, that the logistics can deliver these vaccines or testing. I mean, delivering scientific solutions, it's very similar. But then you get into the attitudes of people, and we're back to social science. There does seem to be a heightened level of vaccine hesitancy across some countries. And how do we get out the right health messages so that vaccines and testing and actually infection prevention and control and face masks and everything have the impact that they surely could if only people were able to hear it effectively.
Thank you, Sally. Let me turn to the good doctor from Partners in Health. I bet you have a view on this.
Indeed. First of all, we've been here before. We were here with the HIV pandemic, which got way, way, way out of control before any equitable access to medicines was in place. In fact, we had the highly active antiretroviral therapy in 1995, and in 96, 97, 98, 99, 2000, 2001, 2002, for fully 7 years, 8,000 people died a day in the global South for lack of access to medicines. And when we queried, it's too hard, it's too expensive, we don't have the technology, a lot of R&D went into this, we can't make it affordable. We just have to reject those things. And so I would say Partners in Health really stands in solidarity with global organizations calling for a people's vaccine, one that's made free and accessible in a timely fashion to all people. We were thrilled to hear Dr. Fauci in yesterday's session that we had support COVID-19 technology access pool. We have long talked about the trade-related aspects of intellectual property, or the TRIPS flexibility, but we know that that is a tedious and country-by-country process to put flexibilities to do parallel importing or compulsory licensing into the law of each land. And with this new technology of an mRNA vaccine, that doesn't even hold true because it's know-how, not just the patent. And so we really need a broader view for what is our shared destiny as humanity. And I agree with Dame Andrews that social science is important, but I would also add that the social science to try to understand the acceptance of our leaders around the world for a wildly different standard of care for those with money and those without. We need social science to unpack that and really debunk in my opinion, and our opinion at PIH, the racism and historical injustices that really underpin that belief system. PIH has joined the People's Vaccine Alliance with more than 100 organizations, and we publicly support COVAX as well, which aims to supply 2 billion doses of the vaccine. But we know that's not enough. And so we really need to do as we did for HIV, which is take a look at the math, figure out what we need, raise the money for that, and then really move to a mass production strategy that includes licensing and sharing of know-how and any kind of patent protection so that we can all get out of this together.
So I think we're going to conclude at the end of this panel that this team is going to be put in charge of the world. I think, Anjali, let me just add a couple things to what we've got. Some really key points here. One is that it's not just vaccines, that there's a whole host of things that need to be available on a more equitable basis globally. Vaccines, therapeutics, PPE, and so on, and that we are seeing real cost in terms of human lives and the capital that we're spending on managing this pandemic out of our failure to do so. I think we're hearing that we need the affordability, the deliverability, and the social science in two ways. What is the underlying social science that we need to tease up to get the uptake we need to counter the hesitancy we're seeing? But also, what is the social science we need, which is a much bigger question, but one which has proven very salient in the case of this pandemic, to deal with the underlying structural inequity that is driving the response. I would add to that, I think that as a practical matter, there's COVAX as a first order, and COVAX is a great idea. It is far from fully funded. It is dramatically underfunded at this point. So that's something that is critically urgent. The second is, we all know that wealthy countries, as we have seen in H1N1, as we've seen in other cases, have bought up far more supply than will be needed, hedging their bets. I understand that, but that means that they will have surplus. It also means in the short term, there's less available to other countries. How's that surplus going to be managed? I think the third is that there are other ways to finance vaccine availability that can be looked at, whether it's DFIs, export credit agencies. There's a number of things that could be considered. But I think the fourth and final is, if we're really talking about preparedness into the future and building on the point about the people's vaccine, or about what we learned in HIV and AIDS, which is that we have spent billions more than would have otherwise been necessary had we moved earlier on treatment and testing availability and cost, and lost many more lives, and arguably have a much broader epidemic still today than we otherwise would have had. So I would argue that part of what the world needs to do is establish a protocol for declared epidemics or pandemics, that there is going to be some set of rules that ensures that therapeutics and vaccines are equitably available everywhere. It is more cost effective, it saves lives, it can shorten the lifespan of the pandemic. It takes a lot of political will, and I think we're seeing a deficit of political will. But I think both budgets and science inform it. And I think, Sally, to your point, one of the things we need to do on the social science level is, yes, underscore and fight back against the underlying racism and sexism and other isms that drive this, but also play to enlightened self-interest. We will shorten the lifespan of this pandemic in all of our countries if we work collectively to get it under control everywhere. We will shorten the impact and lifespan of future epidemics or pandemics if we do the kinds of things you all have recommended in terms of healthcare equity and sustainable investments over time. So I think, let me go another quick round, because again, we're solving all the world's problems right here, and this pandemic has to be brought to an end in 11 minutes. But on a serious note, I think we know we've got a false dichotomy, but unfortunately a very real life of facts and opinion being conflated. I think we've not seen the political leadership we need. What do we think that our politicians need to do to forge the kind of responses we need? It's hard. I realize everybody leading a country has to deal with tremendous demands from their own countries. But if we really want to see preparedness for the future, how would you quantify what are the things you would like to see from where you sit in terms of political leadership? Amanda, what must they do?
I mean, well, I think it's back to basics. I think we have an opportunity of a lifetime. If we don't fix this now, when? We've been in this cycle of panic and neglect with epidemics and pandemics and then de-investment, and we haven't been able to maintain that political will. And I think in part, the return on investment case seems very clear to us in the health sector, but it's been something that we really struggled to explain to ministers of finance and to get onto the agendas of governments and keep it there. And I think we need to make sure that this isn't seen as just a health issue. This is a societal issue. This has impacted trade and travel. It's impacted economics, social cohesion, and health. And we need to make sure that we're packaging epidemic and pandemic preparedness not just as a health issue, but as an equity issue, as a security issue, not just nationally, but globally. And I think if we can package it outside of the health system with health driving, but not necessarily the only system impacted, we'll be able to generate more political will driven by that return on investment and backed up by those access and equity issues. And I think making it clear that the pandemic and epidemics find cracks in the system. Every crack, whether it's in a country that was controlled or a country that's in chaos, the pandemic has exacerbated cracks in the system. And so really highlighting the systems approach between health, society, and politics and reinforcing across the system is going to be critical as we go forward.
Okay, I'll vote for you.
Thanks.
Sally, let me turn to you.
Well, let me pick up first on that about votes. The ism we didn't mention is nationalism, and it relates to votes, doesn't it? And why do politicians behave as they do? Because they worry if they don't take their population with them, they won't get the votes and then they'll be out. And so that absolutely goes back to how do you communicate the fact that we are all in this together. And I think that I want to build on what Amanda said about this linkage between health and wealth. And it is clear, I think it's been clear for some time, but it's become very clear during this. But somehow it's a conversation going on in the health space. What are we going to do to get the finance ministers talking about health and wealth? I've, through data, been having conversations with reinsurers and people because it matters to them. And that's one of the things we're doing through Trinity Challenge, bringing in all these people who have data, but have an interest in getting on top of this and trying to change the discussion from health and wealth to wealth and health and get the wealth leaders to lead that debate. But then I also think we need to look at what are we talking about in pandemics. We know Ebola will keep coming back. So why are we not supporting DRC to be much better prepared up front? We know that coronaviruses will come back again and again. So how is it that we're not keeping an eye on the zoonotic transmissions in the hot spots of the world and making sure that we clamp down on them quickly and that we're better prepared in the north than we were this time? And the last one I'll give you, because I have been working on it for a few years and I'm really concerned about, is if COVID is the lobster dropped into boiling water and making a racket because it's dying fast. Try antimicrobial resistance. The lobster puts in cold water, making no noise and heating up slowly, but it's going to die, and it's killing hundreds of thousands across the globe already, and it's only going to get worse. How is it when we can tell you the financial impact from modeling and everything that we still have difficulty persuading governments, pharma, to invest in a big way in new antimicrobials, countries to strengthen their health systems so they're doing the proper surveillance and proper stewardship and managing those patients, whether they're in Cox's Bazar or, a major Indian or Chinese city or in London. Why are we not managing on the slow pandemic as well? And it's got to do with the fact the discussions led from health. So we've got to shift that.
Great. Okay, we've got the formation of a new global government in the process. I think those are terrific recommendations. Doctor.
Yeah, as you know, the saying global governance has become fighting words in the United States.
Yep.
And I guess my big response to your question, Gayle, is health is a political choice. And unfortunately, in countries in the global South, those political choices are very much constrained by external actors. So there are many ministries of finance that I've worked with around the world, in Malawi and Lesotho, that very well understand the importance of health, but they've got no fiscal space. And that's as a result of the kind of development we in the North, in the global North, in the West, have pursued, which is purely looking at development in economic terms by GDP, not by the disaggregated effect on the poorest. And again, I go back to equity and say equity should be everyone's business. I think what we've seen with globalization is that we are more interconnected by the internet, by travel, and yet our fates and our fates are interconnected, as we see with COVID. Yet our investments in health as a human right are not interconnected, and they need to be. And again, back to HIV, we've got almost 30 million people on highly active antiretroviral therapy, and 17 years ago, that would have been considered just absolute pie in the sky. And that happened through activism, through making common cause. And so I just feel that, we need to, as a global community, make the political choice. And where is that money going to come from? Frankly, the political choice we make every day on implements of war, on ongoing destruction, on, things that could so easily go into the common good, and we have to push for that as a society. Globalization cannot just be about profit. It must be about who gets the fruits of modernity, and particularly in the health space and education. And so, when you think of something like antimicrobial resistance, I work in many countries around the world. There's not a single microbiology lab in those countries. So how can we be serious about this when the infrastructure to actually do this isn't there? And yet nobody has made these countries clamp down on the size of their armies. So we really need a very different contract, I would say, for the 21st century on what globalization looks like.
I would certainly agree with that. Yes, go ahead, Sally.
I just wanted to pick up, I absolutely agree. We use the wrong measurements, and we talk often in these discussions about GDP, which is about flow of money, and we ought to talk about the stock of health. And we've just launched our Office of National Statistics, a beta version of the National Health Index, which they are developing and consulting on to make a national statistics that looks at the stock of health across England at the moment, and it will be the UK, as an attempt at my request when I was the chief medical officer to try and get into this. How can we measure where we are and watch what we do politically and in action and its impact on our stock of health?
I think that's really, really important, because a lot of the discussion about what the world must do is about what data we need and how we use it. And I think this is a key point. We don't measure the right things. And so I think the first thing we're all talking about is we need to be measuring more on the outcome side and data that yields evidence about equity. Because equity, again, is not just a matter of right and wrong. It's really sound for the science in managing a pandemic or any kind of health crisis. AMR, you're 1,000% right. That's number one. I think number two, the reference to finance ministers and economists and people who make some of the big decisions. We have an opportunity right now in terms of the costs that have already been incurred in responding to this pandemic on the health side, or quite frankly, on the economic stimulus side. And we could finance multiple times over the most exquisite, comprehensive, equitable, global preparedness system imaginable for a fraction of what's already been spent. That point needs to be driven home, not just for response to this pandemic, but Sally, to get to something you referenced in AMR, we are not doing the financing between crises. We're at risk of doing the same thing. You have a crisis, you respond for a while, you forget about it, turn to the next thing. So how do we put the data and the evidence out there to sustain that funding over time? I think third is that we need advocacy and activism to convey to political leaders that these things matter to us. And I think unless and until they hear that consistently, it's going to be very difficult to break the cycle of telling people what they think they want to hear, which is this is not a problem, or wear a mask if you feel like it, or we don't really need to worry about whether there are vaccines available in Malawi. So I think there's also a need for a coming together of citizens all over the world to say, we know we can do better, we expect it, and here's what we want to see. So my hope as the clock turns to zero is that all of us in this forum can do something by pulling all of this together. And that means thinking about preparedness from the perspective of health, thinking about it from the perspective of science and data. We know what we can build and engineer, but think about it in real practical terms and express our views on this, that it's also about our common humanity. Because if we have a belief in our common humanity and act on that, we will face fewer pandemics for shorter times and at lower cost to the benefit of everybody. Let me end there. Thank everybody. Anjali, thank you for your question. Keep asking it. Don't ever stop. Thanks very much, everybody.
Thank you. Thank you.
Thank you.